Dr. Karthik. Dr. Karthik is a retina consultant at Arvind Hospital, Chennai. And apart from his Vitretina fellowship, he's done a postdoctoral fellowship in AI and data sciences. And therefore, he would be talking to us on this important topic of smartphone-based retinal imaging and use of AI in retinal imaging. Over to you, Dr. Karthik.
At the outset, I'd like to thank Dr. Sharath for inviting me here. So, this is the upcoming field of AI. So, right now, whatever you listen to is what you guys use regularly in the field of clinical ophthalmology. And all the information I'm sharing over here is my personal capacity working with Arvind. I'm not generalizing. I'm just talking about what we do generally at Arvind Eye Hospital with AI. So these are the headings that we are going to talk on: teleophthalmology, diabetic retinopathy, glaucoma, corneal disease surgery, systems biology, and what exists in the future. Why do we have vision centers at Arvind practice? So for people who are unable to come to the base hospital on a day-to-day basis, who are unable to travel, they visit a place which is at a constant distance from their home. At a population around 50,000, we have a localized ophthalmic clinic where it is open 6 days a week. So because of that, we make specialized eye care accessible to all the patients in that population, where we undergo comprehensive eye screening. And we do not have one doctor going to that particular vision center and treating the patient. We have one doctor who's in charge of 10 vision centers. So based on that, we have teleconsultation and prescription that are given. And we bridge this gap of having a doctor virtually present by using technology. And we use our electronic medical record and a teleconsultation network, and also use AI for it. The typical flow is what we have in a regular clinics. Everything is done according to what an ophthalmologist would do, but we have a mid-level ophthalmic personnel who is trained in doing a similar task of what an optometrist would do. So when we bring about smartphone imaging and fundus imaging to this type of a setup, where we need to know what is the utility of a routine fundus photography screening for posterior segment disease. So screening for posterior segment disease can be various. It can be for mass screening, where in a camp you can do it, or a high-risk screening, where only those who are at risk, like a diabetic clinic, or an opportunistic screening, where patients come for any drug toxicity or related medical problems for screening of the retina. So all the fundus photos that are recorded at the vision centers are seen at the base hospital virtually using a Google Meet network. And with this, we have seen about, in 2022, about 900,000 cases, and we have referred cataract surgeries around 67% and specialty care about 50,000. So this is the amount of patients that we could send using teleophthalmology, and we currently do around 3,000 teleconsultations a day using this kind of a setup. And this year 2023 to 25, we are reaching 1 million patients through the vision centers. So this was a setup where we used teleconsultations at the localized centers, which is a virtual center. Then we thought about where else can we do mass screening. In a traditional eye camp, whatever we do, we generally go there, check the patients. We majorly conduct only screening camps for cataract. We do not think about any other implications of the retinal posterior segment disease. No glaucoma, no retinal disease. We just pick up the cataract and come back home. So then we thought about putting in how to screen for glaucoma using tonometers, how to take care of the digital fundus photography. So all patients who are undergoing camps right now go through this novel eye camp where digital tonometry is being done. And all patients, irregular of whether they're going to undergo cataract surgery or they be given prescription glasses, are taken a fundus photo. And once a fundus photo is taken using Wi-Fi, that fundus photo is transferred to the electronic medical record, and where the doctor sees the fundus photo and then decides whether it is going to be a posterior segment disease involving patient or a non-involving patient. So because of this, the referral for the posterior segment disease has increased to threefolds. So this threefold increase of detecting patients who are in requirement of these posterior segment disease has increased the uptake of these patients coming to the base hospital. So the service delivery model, why we have these vision centers and why have these camps, is already known to everyone. Now coming to diabetic retinopathy, if in case you see a diabetic retinopathy patient in the clinic and you have a fellow that you have to teach, you would give them main points like mild NPDR, single microaneurysm, moderate NPDR, more than one microaneurysm, severe NPDR if you watch an IRMA. So same calculation, we put it into a computer and we gave them a ground truth telling that if this image is there, are you going to give an yes or a no for the following questions? So this was early Arvind diabetic retinopathy evaluation screening system, where we used a ground truth and we used a doctor to indicate the presence or absence of diabetic retinopathy. Following this, then we met with Google and we had a technological collaboration with Google, where we came up with an automatic analysis of using an AI algorithm to detect whether diabetic retinopathy is present or not. So what this algorithm does is it gives you a clinically graded diabetic retinopathy screening, whereby it requires the algorithm to tell you whether it is a referable case of diabetic macular edema or it is going to be a referable case of diabetic retinopathy that needs to be seen by a retina specialist. So this does not omit the retina specialist in treating the case. It just gives you a guidance whether it needs to be referred or not. So this is the report that is generated by the AI algorithm that is at the place of the screening taking place. It can be at the camp, it can be at a diabetic clinic, it can be at anywhere. All you have to do is upload the image and get the report back. So what are the limitations of this? We have to be constantly checking clinically an audit that is being performed to make sure that we have a retina fellow always auditing the images that are being taken by the fundus photographer to check whether the media opacity is clear. And we also report to Google if there are any outcome measures that are not good. And we'll also have to monitor whether the algorithm is doing a good job of detecting moderate NPDR as moderate NPDR and not missing a diagnosis. So once we have set that diabetic retinopathy, we have finally said, okay, and the algorithm is doing a sensitivity and specificity of about 90%. We moved on to glaucoma. What else can we do in glaucoma? So in glaucoma, we came about with an offline on-the-edge AI integrated on a smartphone fundus camera, where it generates a retinal referral report in about 10 seconds. So what you do is you take a smartphone using a fundus camera, you just take a snapshot, and even if you don't have electricity or an internet connectivity, the smartphone has the capability by using an app to detect whether there is a glaucoma that needs to be referred or not. So the healthcare worker or any operator who uses it in a mass screening program or in your clinic where you want to screen as a comprehensive ophthalmologist, you can always use this to detect the presence or absence of glaucoma. So it not only gives you the presence or absence of glaucoma, it also states where the pathology is, and it also indicates the cup disc ratio and the evaluation of any RNFL nerve fiber layer defect. If it is going to be there, it is going to indicate where it is particularly present. So with this, did we prove that it is better than a doctor who is going to see it? Yes, we did prove that it has a specificity of 98%, and it gave a 96.4% of definite glaucoma diagnosis when compared to a 53.5 by a general ophthalmologist. And the false positive referrals in a camp, when you bring in 10 glaucoma patients and say that 10 are not glaucoma patients, you have to reevaluate, then it brings the patient no value gain of bringing him to the base hospital and checking him up. But the AI algorithm gave you a false positive referral of 2 of 10. So it is much better than having an AI tool to guide you in these things. What are the limitations? If you have an algorithm detecting glaucoma in a fundus photograph, it will detect only glaucoma. It will not detect BRVO, it will not detect ARMD, it will not detect other pathologies that are present. And if you require other modalities like OCT to be seen, that is also not there. And you'll have to work with multiple vendors. One might use a Mac OS device like an Apple iPhone, and another would use an Android. So you'll have to limit your modalities to using what algorithm for what kind of vendor to use. And you'll also have to tune your model. Sometimes you might have a patient who, if suppose I'm going to use the same algorithm in Japan or in the Europe areas, the Asian eyes are not equal to their eyes. So then you'll have to change the modality. So, or if a guy from Europe is going to come and get his algorithm to work in India, then it is going to change the modality. And coming to cornea, if suppose in your clinic, if you see this today, if I see this today and I measure the corneal infiltrate as 4x4 or whatever is to be measured, and I want to see this patient again in a week's time, how will I remember what is the size of the corneal infiltrate? How much has it regressed? Is it improved? Is it worsened? I do not know unless and until I have a clinical photograph. Even when I have a clinical photograph, how am I going to know whether exactly the size is measured or not? If you're going to have a clinical trial or a clinical study going on, it is always a difficult task. So then we came about with an automated quantitative ulcer analysis. We call it as AQUA, where it measures and segments the corneal ulcer, it measures the corneal scar, it measures whatever lesion is present in the central of the cornea. If it is going to be normal, it is going to let you know it is normal. And whenever it comes back with the next clinical episode, it always goes back to the previous one and lets you know what is the difference in it. So we have also done for corneal infiltrates from healed scars, whether it is going to be an active infiltrate in a healed scar or it is going to be a healed scar by itself. Or in cases where you have various other disorders like keratoconus, or it is going to be a normal cornea or any ectasias, it is going to pick up. So these are things that we have done in anterior segment of the eye. And we have also based trying to differentiate fungal keratitis from bacterial keratitis without using a gram stain or other stains. Just by looking at the photograph, the algorithm comes up with a plan of saying this is fungal or this is bacterial. And we also use confocal imaging in vivo to make out whether it is going to be what kind of infiltrate. So moving on to surgical expertise with AI, with the collaboration with the Nalasamy lab at the University of Michigan, we are collaborating to know what are the steps that you do regularly in a regular format. If you have a standard operating protocol for SACS saying that you have a 7 millimeter incision in a frown shape to be made, are you making that incision exactly 7 millimeters? Are you going 6 or are you going 8? Is your pupil during your PCR shrinking, or is it widened enough to know that you don't have a PCR? What is your strategy when you do a phaco chop? All these are going to be calculated and measured so that when you train a person, you virtually can understand what kind of a training has to be given at which particular step so that he can improvise on that particular step and have a less learning curve. So this is what we are trying to do with the surgical analysis using artificial intelligence. Moving to translational medicine. So in translation medicine, whatever you've done till now, you use clinical lab to do tests on drugs, and you use your rat, your mice and things. We have moved on to use systems biology, where we try to do it on a chip. So these are called as in silico trials of using AI algorithm to know what can be done to treat certain kind of diseases. For example, we use Pseudomonas aeruginosa for cases of endophthalmitis to try to see what we can find out on which drug acts better for Pseudomonas. So the most common drug that we use, Gatilox, Vigamox or Gatilox that we use for Pseudomonas, it did not even make up to the top 20 list. So what we are currently using to treat Pseudomonas did not even come up in the top 20, and the computer algorithm gave us a combination of tobramycin and ceftazidime, which is in the top 3. So these are some things that are coming up now where you do not have to do a 6-year trial to find out which drug is acting better. You can always do it by using an algorithm. So in the future, what holds for us? Everybody knows that we use ChatGPT for each and everything. And for your information, this is not by ChatGPT. This presentation is made by myself. And for people who want to try out new things, there are possibilities of using ChatGPT to find out what is the newer research that is going to happen. On what, depending on your prompt, you will know what to do. And this is the upcoming things. It is better that you embrace this technology rather than saying this is false, this is not good, this is unethical. It is better that you start embracing. So what in the future holds for us? We would require a co-pilot. It is basically like if you're a surgeon operating on a surgical field, you will not do the drape, you will not put the eye speculum, you will just do your phaco and come out. So the same principle. You will not do the refraction, you will not take the clinical report, you will just see the patient, diagnose and give him an advice. So that is what is a co-pilot that is going to come up. And based on this, we have already developed a Center for Ophthalmology and Data Analytics at Arvind, where we are trying to answer whatever algorithms that can be created to make the clinician use his clinical knowledge and does not waste his time. So these are our collaborators that we collaborate for our AI collaborations. And with this, I will end my talk. And if you have any doubts, you can always email me. Thank you.
Thank you, Dr. Karthik. That was a great talk on AI in retinal imaging and the future of ophthalmology. Very exhaustive talk.